Welcome to the Thursday, July 26th edition of the Daily News Podcast. I'm Terry Rudd.
And I'm Mary Ellen Schneider. Today, new guidelines urge speed and triple therapy when targeting HIV.
Also, early antidepressant therapy after a heart attack delivers benefits years later.
And HIV infection could double a patient's risk of stroke.
But we start today with a remarkable discovery. Antihypertensives prevent mild cognitive impairment, and they appear to decrease the risk of all-cause dementia in people with cardiovascular risk factors. Drug class? Doesn't matter. Cheap generics are just as effective as expensive name brands. The approach equally benefited whites, blacks, and Hispanics. And the simple intervention in the 3-year Sprint Mind study worked as well for those older and younger than 75. The stunning announcement came during a press briefing at the Alzheimer's Association International Conference. Dr. Jeff Williamson of Wake Forest University unveiled the results. The Sprint Mind study included more than 9,300 patients who were 50 years or older and had at least one cardiovascular risk factor. Strict blood pressure control with a systolic target of 120 millimeters of mercury or lower reduced the incidence of mild cognitive impairment by 19%. That's a magnitude of benefit that no amyloid-targeting investigational drug has even approached. However, the study's primary endpoint, the 15% risk reduction for all-cause dementia, didn't meet statistical significance. So, how should physicians incorporate the findings into practice? Dr. Williamson has this advice.
As a physician, even for my own self and for my patients, I'm going to adhere to these, especially the guidelines that say that it's good for people to have a blood pressure control at least less than 130. And to start that, are certainly in your 50s and probably in your 40s.
For adult patients with HIV, earlier treatment delivers faster and more likely virologic suppression, and it provides greater linkage to care. That call for speed is the primary message from the 2018 recommendations of the International Antiviral Society, USA, published in JAMA. The updated treatment and prevention guidelines also outline drug selection, including 3-drug therapy, usually as a single tablet combination, and 2-drug switch therapy. They also discourage cash incentives for treatment. Dr. Michael Sagg of the University of Alabama at Birmingham and his colleagues wrote the guidelines. New research prompted the updates on the last recommendation, published just 2 years ago. Among the science that spurred the changes are multiple studies showing the importance of timely antiretroviral therapy. In one study, for example, patients with HIV who started antiretroviral therapy within 24 hours of diagnosis achieved virologic suppression faster than patients treated according to previous guidelines. The expert's choice for initial treatment is 3-drug therapy, incorporating an integrase single-strand transfer inhibitor with 2 nucleoside reverse transcriptase inhibitors. 2-drug regimens aren't recommended for initial therapy, but they may be considered as switch therapy to cut cost and complications. The new guidelines give cash incentives for adherence a thumbs down because they just don't work. Non-cash incentives, however, are likely to be beneficial.
Treating acute coronary syndrome patients' depression with 6 months of an antidepressant led to fewer cardiovascular events for years afterward. Compared with patients given placebo for depression after experiencing acute coronary syndrome, or ACS, patients who received escitalopram experienced a lower incidence of major adverse cardiovascular events, or MACE. Those were the findings from a randomized placebo-controlled study of 300 South Korean patients who recently had ACS and met criteria for major or minor depression. After a median of 8.1 years, 41% of patients on the antidepressant had a MACE, compared with 54% of those on placebo. Myocardial infarction was also significantly less common in the escitalopram group, compared with those who took placebo, 9% versus 15%, respectively. The study didn't show an overall mortality benefit for patients taking the antidepressant. Dr. Jae-min Kim of Cheonam University in Gwangju, South Korea, led the study. He says his trial differed from other studies on the effects of depression treatment because it followed patients for a longer period of time. The findings appear in JAMA.
Patients infected with HIV had a roughly doubled rate of stroke compared with the general population. That's according to an analysis of data collected from about 23 million people in Taiwan, including nearly 6,000 with HIV infection. The combined rate for both ischemic and hemorrhagic stroke was especially elevated during the first 7 years after an HIV diagnosis. And in the first year after diagnosis, patients had a nearly 47-fold increased incidence rate. In years 1 through 7, there was a nearly 4-fold increased rate compared with the age and sex-adjusted general population. The excess stroke rate was particularly significant among HIV-infected patients aged 65 or younger at the time of diagnosis, and the rate was higher in women than in men. However, 8 or more years out from the time of HIV diagnosis, infected patients show no significant difference in their stroke rate compared with the general population. Dr. Hu-Wei Lin of Linshin Hospital in Taiwan presented the study at the International AIDS Conference. He says the findings highlight the importance of screening for stroke risk factors and then taking steps to minimize that risk immediately and aggressively after diagnosing HIV infection. And that concludes this edition of the MD Edge Daily News. You can subscribe to the Daily News wherever podcasts are found. For MD Edge, I'm Mary Ellen Schneider.
And I'm Terry Rudd. You can always find these stories and more at mdedge.com.